Okay, I think we're going to get things moving now. If you're here for the Magstim TMS webinar, you are in the right place. I want to welcome you. I am honored you're here. My name is Mark Sabar. I'm the Global Marketing Communications Manager here at Magstim, and welcome to our parent company. We are a research-based neurotechnology organization, and we're honored you're here to share insights and more on today's webinar, which is TMS and chronic pain management, where goal is to continue to provide education and facts on the applications of all these technologies therein. I am going to run the webinar today. Please remember to add questions in that Q&A section down below because I will be able to monitor that. We'll be addressing those Q&As questions at the end. So think of some good ones, please. With that, I want to turn it over to our CEO, Ronnie Campo, for a welcome. Ronnie, how are you today?
I am doing great, thanks. And I can't even tell you how excited I am for this webinar. So I met Stevie and Aimee a little over a year ago and absolutely fell in love with their research. So thank you all for joining us today. Thank you, Mark. Thank you, Stevie and Aimee. John, for being here to manage the questions. Thanks to all of you joining us, researchers, clinicians, neuroscientists, everyone who studies and treats conditions of the brain. We at Magstim EGI are grateful for your work, for you, and we're committed to supporting your research and your clinical growth. Today, we're bringing you an exciting webinar that shares insights on latest research applications of TMS in chronic pain management and treatment. Truly, TMS for pain represents an evolution of TMS, grew out of the research market, and certainly takes it farther than depression, OCD. Absolutely, this is research and treatment that will change lives. We're excited for you to meet Dr. Aimee Nelson from McMaster University. She is also Chief Scientific Officer at Neuro-Mod, and Dr. Stevie Foglia, also from McMaster University and the CEO of Neuro-Mod. We're going to learn about their research for TMS and how they're using it to manage conditions of chronic pain. Doctors Nelson and Foglia will present the latest results in pain management utilizing TMS. This team also will share practice insights, how to get your practice up and running, and how to grow your practice, how to help your patients who have chronic pain. I need to read the following legal statement to keep our attorneys happy. So here we go. Scientific content remains the intellectual property of the authors. This webinar is sponsored and organized by Magstim EGI. However, Magstim EGI does not engage in generating or editing scientific content presented. Inclusion in this webinar should not be taken as an endorsement of scientific findings by Magstim EGI. Please note, the use of Magstim devices or EGI devices for other than the cleared intended uses is considered investigational. Also joining us here today is John Leadham, our VP of Research Products and Business Development. John, I will turn it over to you, and then you can turn it over to Drs. Nelson and Foglia. Thank you.
Thank you, Ronnie. Thank you, Mark. Really looking forward to this presentation. Just a quick reminder to everybody to put your comments or questions in the Q&A. We'll get to as many of them as we can. I too think that pain is a very exciting space and lots of promising research going on in TMS and pain. I'm also excited that Stevie and Aimee can join us because, as I was just saying, they're the very closest lab to my house, so they see me more than anybody else, and it's great to see them up front here presenting their great work. So at this point, I'll turn it over to Aimee and Stevie, and please enjoy.
Perfect. Thank you very much, Ronnie, John, and Mark, for organizing this. We're very excited to have the opportunity to showcase the work we've been doing in research at McMaster University over the last 4 years, providing insights into the latest treatments that are happening using rTMS in chronic pain, and ultimately transitioning into how we can utilize this technique in real clinical application to benefit the patients who really need it most. So just before we get started, a general overview of the webinar today. I'll be discussing a brief history of rTMS in its specific application of chronic pain treatment. And then we'll move into the research that we've been working at McMaster on, starting in rTMS for neuropathic pain with a specific emphasis on different pain phenotypes and how rTMS may preferentially benefit certain pain experiences over others within the chronic pain spectrum. Moving into our larger study using rTMS in patients with complex regional pain syndrome, spending some time discussing potential analgesic mechanisms for why rTMS may be beneficial for chronic pain. And then transitioning into some really exciting work that we've been conducting at McMaster, where we're pairing brain stimulation with rTMS with novel technologies that we have developed in this pairing approach to potentially enhance overall benefit and outcome for patients with chronic pain, specifically in this application, patients with complex regional pain syndrome and patients with chronic neck pain. And ultimately, we'll discuss how clinicians can potentially implement this new type of therapeutics within their clinical offerings to benefit patients of chronic pain of different origins and phenotypes. And so really the necessity for exploring rTMS within chronic pain is really based on the epidemic that is chronic pain globally. And even just within Canada alone, we see chronic pain impacting approximately 20% of the population. That represents 8 million Canadians that suffer with some form of chronic pain. And it puts immense healthcare pressure on the Canadian ecosystem, with over $23.4 billion being spent annually on current treatments for chronic pain. And these treatments involve opioids, anticonvulsants, antidepressants, sympathetic blockades, and surgeries. But one of the main issues with current treatment options is that there is a severe risk of side effect and are invasive in a lot of these applications. And ultimately, as reported by the NIH, we see a large proportion, up to 70% of individuals, not experiencing adequate relief of their symptoms from these traditional pain management therapies. And so there's a real opportunity here to use novel therapeutics such as rTMS to potentially benefit patients who have not experienced relief from traditional pharmacological or surgery type interventions for their pain. And really, the history of rTMS within the chronic pain space stems from a natural progression from motor cortex electrical stimulation. And about in the mid 1990s, the thought was that we could use rTMS to target the same motor area, but in a non-invasive way compared to traditional electrical stimulation. And really, since then, there's been a proliferation of research over the last 25 to 30 years applying rTMS in various chronic pain populations and conditions. And what's really interesting in this area is we hear a lot about rTMS and its use for the treatment of major depressive disorder. But what's interesting is that rTMS in pain has been around for the same period of time as the work in depression, and really has been growing in its literature across the globe and its application. And really that 25 to 30 years of research spans across various chronic pain conditions. The most prevalent that we see in the literature is the use of rTMS within neuropathic pain and fibromyalgia. We're also seeing exploration into other pain conditions such as cancer-related chronic pains, endometriosis, complex regional pain syndrome, and more recently application of rTMS for the treatment of chronic musculoskeletal pains. So this being things such as chronic neck pain and chronic low back pain. And so there's really been a global effort within this area of determining the efficacy of rTMS within these populations. And really our introduction into this space came just coming out of COVID in the summer of 2021, where a clinician we worked with at St. Joseph's, Dr. Harsha Shanthana, had a patient with a spinal cord injury and had unresolved neuropathic pain for 11 years and had tried every treatment possibly available for that patient and did not experience relief. And so Dr. Shanthana approached Dr. Nelson and I, and we determined to create a case study using rTMS for this patient to potentially offer some type of relief for their pain. But what we wanted to do was approach this in more of a unique way in how we describe the pain experience of the patient. And typically with rTMS in the chronic pain space, we look at pain as more of a global phenomenon, and that's typically reported using a scale such as the numerical rating scale, where a patient would indicate from 0 to 10 how intense their pain is. But what we realize is that that might be only showing a small picture of the overall pain experience of the individual. And as was reported to us by this patient, the individual identified 4 distinct pains that they had experienced. And so we wanted to track these pains individually and determine their effect with rTMS. And so the pains that this patient described was a left foot continuous pressure-like pain that felt like the foot would pop at certain times, a burning pain, allodynia type pain in the sternum that was aggravated through touch in that area, a sharp electrical sensation in the buttock and pelvic region. And the most notable to the patient as being determined as the most severe was what they described as electrical attacks, whereas this electrical pain that would begin in the left flank and would radiate throughout the torso into other limbs in the body. And this was described as the patient as occurring 3 to 5 times per day, and would typically last about a minute to 2 minutes. And it was an excruciating pain that would prevent the patient from doing anything while within that pain experience. And so we tried the patient with an rTMS protocol that we had developed based off of what had been coming out of the literature in neuropathic pain and rTMS. And that was a 6-week rTMS intervention at 5 sessions of rTMS per week over the 6 weeks. So a very intensive and rigorous procedure targeting the primary motor cortex as our stimulation target across those 6 weeks. And what we found, if we look at these 4 pain phenotypes individually, is we saw a significant reduction or clinically important reduction in all pain phenotypes, with the most noticeable change being a complete abolishment in these electrical attacks that the patient was typically experiencing 3 to 5 times per day. And so we saw a reduction of about 30% in these other pain areas. And so we then followed the patient for a 6-week follow-up without any rTMS. And what we've noticed was that these pain phenotypes were beginning to increase and regress back to the level that they were seen at baseline prior to the rTMS intervention. And so consulting with Dr. Nelson and Dr. Shantana, what we decided was to try the patient with what we describe as top-up sessions, which was a once-a-week session of rTMS performed for 8 weeks in the hopes that we could potentially reestablish the pain relief that we had achieved during that initial 6-week period. And we did see promising effects in these different pain phenotypes, and we were able to re-abolish those electrical attacks over that 8-week period. And so this was really exciting for us to see, as this was our first-hand experience to show that rTMS may be beneficial for patients with chronic neuropathic pain, but really also highlighted the need to potentially adjust our protocols so that we could promote longevity of analgesia far beyond the period of stimulation that we would typically do with the treatment. And if we look at the neuropathic pain scale here in the patient, you can see a very similar trend where we have a significant reduction, a clinically meaningful reduction during the treatment period, followed by a regression during follow-up, and then a somewhat reduced sensation during those top-up periods. And coincidentally, at this time when this work was being done, one of the largest studies at the time was published in Brain in 152 patients with neuropathic pain. And the idea in the study was that rTMS longevity could be enhanced by introducing what was known as a tapering period. And so what we would do is try the patient with an induction period of TMS. This is a rigorous period of sessions, typically 2 to 4 weeks at 5 sessions per week. And then rather than halting rTMS completely and moving into a follow-up, we would then taper the sessions gradually over a certain period of time to potentially enhance the analgesic effects of rTMS that was achieved during that induction. And indeed, this paper in Brain had indicated that you could prolong longevity up to 22 weeks by doing this tapering type protocol. And so at this time, we were moving into a larger study in chronic pain, specifically in complex regional pain syndrome, and had just finished this patient in neuropathic pain and wanted to combine these findings with this tapering period in order to explore its effects in a very severe and intense pain population, that being CRPS. And CRPS is very unique in terms of the chronic pain spectrum in that it has associated very severe pain intensity, but that's also associated with changes in peripheral motor control, the autonomic nervous system, as well as sensation. And you can see here in 2 patient examples, the affected limb begins to swell. There's a discoloration of the skin. We see muscle wasting and bone degradation, deficits in motor control, and ultimately very severe sensitivity, where even a light touch feels like a very severe stabbing sensation. And it's really rated as one of the most intensive chronic pain conditions. What's particularly unique is that the magnitude of the condition far outweighs the inciting injury. And some of these patients that came into this study had an injury as small as a sprained ankle, for example, that would then lead to these cascade of changes and ultimately resulting in CRPS. So we really want to see if rTMS could benefit this more intense pain population that traditionally has not responded well to current analgesic opioids surgeries that are available to them. And so with the information we learned in that neuropathic pain study and that recent study in brain, what we created was this induction tapering protocol where we performed 5 sessions of rTMS per week for the first 4 weeks of induction. And then we performed a gradual tapering of rTMS sessions over a 5-week period. And so this is a 9-week intervention of rTMS, again, targeting the primary motor cortex. And we performed a 6-month follow-up with these patients to determine the longevity of that relief. And if we look at our pain intensity here, so this is the numerical rating scale on the left, what we saw on average was a 20% reduction in pain intensity immediately following the induction and tapering periods. And then we saw a gradual reduction in that effect up to the 6-month period. But what's interesting is if we look at the individual level, we can really start to see a larger picture here that I'd like to get into about rTMS and chronic pain, and that you have responders who respond to the initial therapy and then regress after in the follow-up period. You have individuals that respond and maintain that effect into the follow-up period, and you have individuals that did not respond at all. And so this was unique for us to see this, because what we had seen was in pain intensity, and this is typically what's used to define responders versus non-responders. We have a very classic presentation here of this proportion of people who have an effect who don't. But if we look at other symptoms of CRPS, we see a much bigger picture. And so what we wanted to also explore in addition to pain intensity was this phenomenon of allodynia that's very common in CRPS. And the scale we use to study this is the rainbow pain scale. And so we use monofilaments of various sizing, and we probe the affected area in different dermatomes in order to determine if there is pain present in that area, and if so, what size of monofilament elicits a pain response. The idea being the smaller the monofilament that elicits pain, the more intense the presentation of allodynia in that patient. And you can see here an example of these 5 patients with CRPS in the foot. You can see all of them present with allodynia to some level at baseline. We then tracked allodynia during the induction period and immediately following the intervention in all patients. And what we saw was quite a remarkable result in that pain improved in terms of allodynia in all patients, with some patients actually showing a complete abolishment of allodynia in certain areas of the affected limb. And what was really interesting to us is patients that would typically be identified as non-responders if we were just to look at their change in pain intensity were responding in other ways that were actually more profound and beneficial for the patient, as they would anecdotally tell us, as this symptom of allodynia was their major primary symptom of concern for their condition. And so it really made us understand that we need to more fulsomely look at the pain experience and these different symptoms of pain to truly understand how someone is responding to rTMS, in that it may affect other symptoms than just pain intensity. And so getting into this idea of response rates in rTMS and its application in chronic pain, there's been several large meta-analyses that have looked at data across multiple different pain conditions. And really the conclusion that's starting to come out in terms of rTMS efficacy is that it has a level A evidence for its use in neuropathic pain. And even so far as going as the US Department of Veterans Affairs indicated that rTMS could be a potential option for the treatment of chronic neuropathic pain. So we're seeing very strong benefit and effectiveness in that area. But if we look at rTMS analgesia across multiple pain conditions, we see a magnitude of effect of about 20 to 45% reduction in pain intensity, and ultimately a response rate that ranges from about 30 to 60%. And so this is promising given the response rates that we're seeing with traditional pain therapeutics, but also as a scientist excites us with potential new opportunities where we can optimize rTMS delivery in order to increase not only the magnitude of rTMS-induced analgesia, but also the number of responders to rTMS itself. And really what we think this comes down to is the limitation of potentially using rTMS currently in its form as a monotherapy. And ultimately, we're bound to yield a proportion of non-responders who have a neurophysiological mechanism of disease that does not match that of the monotherapy itself. And so what we really propose in science and where the field is going is 2 ways to enhance outcomes in pain using rTMS. And the first is through a better understanding of the analgesic mechanisms of rTMS, and ultimately using those mechanisms to better prescribe rTMS, personalize rTMS to patients in order to improve patient outcomes. And really what we know now is we have a driving stimulus of rTMS that's typically targeted over the primary motor cortex for chronic pain, irrespective of the location of pain within the body. We then have some neurophysiological effect that occurs as a result of that stimulation. And ultimately, that leads to a behavioral effect that we typically measure through pain intensity. And the majority of research is really focused on studying this behavioral effect. But what's important is that we need to more fulsomely understand this mediator of neurophysiology so that we can ultimately improve this outcome on behavior. And we know there's a lot of different factors and mediators that are governing this effect on pain, but we still have very limited understanding in how these factors relate to each other, how they relate to the individual, the complex interaction that they might play. And so one area of work is really focused on better understanding these contributing factors and being able to target them more specifically to improve pain outcomes. And some of the exciting work is being done using EEG to better understand excitability within the brain and also brain oscillatory activity, and targeting rTMS more specifically within that context to improve behavioral outcome. There's also been work coming out using fMRI and functional imaging to better define personalized targets for brain stimulation rather than using the traditional primary motor cortex as the stimulation target. The second approach to how we could potentially improve the outcomes of rTMS is using rTMS as a general analgesic treatment for pain and a mechanism to induce neuroplasticity, and then combine rTMS with another form of training that is designed to more specifically target the deficits in the pain condition that you're working within. And this idea of pairing rTMS with sensory motor training as an adjunct to have a overall combined influence that's better than the therapies on their own. And this is really the area that excited me and I worked in during my PhD, was developing novel sensory motor training tasks we could pair with rTMS to improve pain outcomes and working in CRPS and chronic neck pain. And the first study we did was in a case control patient with CRPS type 2 of the upper limb. And you can see here from this timeline, so this patient had experienced pain for quite a long duration and had tried multiple different types of therapies and opioids and surgery with little to no effect. And this patient presented with very severe motor control deficits in the affected limb, which was the right hand for this individual. And so what we decided was to create a sensory motor training task that could rehabilitate fine motor control of that affected hand and ultimately pair that with rTMS to potentially enhance function and pain outcomes. And so this is just an example of what we built here. So we used nerve stimulation applied to the digit to cue the patient to complete a goal-directed action with that finger in order to control this UI that we had developed. And we increased the difficulty of this training by requiring coordination with multiple fingers and different types of patterns that the patient would have to perform during the intervention of the study itself. And so we use the same general structure that we had for the larger CRPS study, but the difference being during this induction period, we use the same 10 Hertz primary motor cortex stimulation target rTMS protocol. But then after each session of rTMS, we performed 15 minutes of this sensory motor training task. And again, progressing the difficulty of the sensory motor training task over subsequent sessions during that induction period. And what was really interesting, if we look here, so this is T3 is immediately following the study, and then at T4, we have a 3-month follow-up. We saw a significant improvement in the patient's pain intensity, a clinically meaningful improvement in the patient's pain intensity that persisted and maintained at 3 months follow-up. We also saw improvements in physical function of the affected limb. Similarly, quite a nice improvement immediately following the TMS, but then a bit of a regression back to baseline during that follow-up period. And just to look at some data here more specifically, we also see improvements in pain interference. So this is pain interference with daily activities. We see a reduction from this moderate category of interference down to mild. And we also see improvements in physical function and ability to participate in social roles and activity from moderate to this mild level. And anecdotally, the patient had really expressed the quality of life improvement that they had achieved following this intervention. And again, really exciting to us, if we look at the symptom of allodynia, which we did in our other CRPS study, we see that the patient presented with allodynia on the palmar side of the hand and forearm, as well as on half of the top surface of the hand. And immediately following the intervention, we see a complete abolishment of allodynia at the hand and as a reduction allodynia at the level of the forearm. And again, this was a very exciting result for the patient because this, in addition to the motor control deficits, was their primary concern and symptom that they were experiencing. And this data plus the CRPS larger study is the first to show that rTMS may benefit allodynia in this population, not only in CRPS, but in other pain populations that present with this phenomenon. And so at the same time we were conducting this study in a patient with CRPS, we were also developing a novel sensory motor training task to be applied into a different pain population that we had not previously worked with. And really we wanted to diversify the research that we were doing as we were focusing on pain conditions that present very intensely, but ultimately impact a smaller proportion of the population. And we wanted to transition into a pain condition that may not present as intensely as something like CRPS, but impacts a larger proportion of the population, and that being chronic neck pain. And we also chose chronic neck pain as we have another opportunity to work with a pain condition that has a motor control deficit associated with pain that we could potentially target with a novel sensory motor training task and improve that deficit in conjunction with rTMS. And what we wanted to do to create the sensory motor training is work with this principle of joint position sense training. And this is what's typically done in physiotherapy for patients with chronic neck pain, as we see the patients have a sensory motor deficit associated with their pain, and whether that pain is a result of an injury such as whiplash or has been due to degradation over time as a result of improper posture over years of working at a desk job, for example, we see impairments in motor control at the level of the neck. And so the goal here with this joint position type training is to create a goal-directed action with cervical muscles of the neck in order to track a certain type of pattern that's presented by the physiotherapist using a laser pointer that's attached to the head. And again, retraining sensory motor control through this visual feedback goal-directed action task. And when we were speaking with patients prior to this study about this intervention, what we found was that one of the main limitations patients were indicating to us was that during this training that they would typically be doing in physiotherapy, they are focusing a lot on the pain that they are experiencing during the training itself. And ultimately, that is preventing the potential magnitude of benefit and the potential ability to really fully engage within the training itself, because they're too focused on the sensation of the pain that they're experiencing while doing the task. And so this got us thinking about how we could potentially implement some type of distraction task to allow the patient to more fully engage within the training while minimizing the influence of the pain perception that they would experience during the movement. And there's really this idea of distraction in chronic pain is a really powerful phenomenon that we see. And there's brain imaging data to support why under a distracted condition, someone may not experience pain that they typically would if not distracted. And to give an example here, you can see this individual when they move to the left, which would be considered the painful side of movement. During fMRI, we see an increased activity in brain areas that are responsible for pain processing. And now when we have the patient do the same action to the right, which is be considered the non-painful movement, we see a suppression in activity in those areas. But what's particularly interesting is that when the patient moves to the painful side, but now under the distracted condition, we no longer see that activity that we saw during that same movement, but while not distracted. And so this idea of shifting attention away from the pain and the activity really has a neurophysiological effect on pain that ultimately manifests into a reduction in pain sensation during that activity. And this is a really interesting and exciting opportunity for physiotherapy and rehabilitation, where a patient could better engage within training and minimize their pain experience. And ultimately what we created to provide this distracting, engaging task while also training sensory motor control through joint position sense training is this development called augmented reality sensory motor training. And what we use is augmented reality glasses to display virtual objects into the user's physical environment. And they control this center crosshair here with cervical motions of the head and neck, and ultimately tracking a series of orbs that move within their visual space. And so it's the same principles of joint position sense training, but done within a game environment. So participants are encouraged to get as high of a score as possible while they complete this within a certain time constraint. And what we also are able to do with this AR training is provide a more personalized approach to the treatment itself. And so we're able to understand the physical functionability of the patient in terms of their range of motion, and also scale the difficulty of the training as someone progresses through the treatment itself. And so we can increase the speed, for example, the orb moves, the size of the orb, the pattern of movement of the orb, all of these parameters to really push benefit in sensory motor control over an intervention type period. And this has actually led into an application development now where we've created a smart system that learns based off of the user's ability and automatically scales the training as they progress throughout treatment. And so in this study, this is currently ongoing, but I'm presenting here are preliminary data that I'm also actually presenting at Clinical TMS Society here in the middle of June. We have two groups. One group is receiving real brain stimulation at 3 to 5 sessions per week for 4 weeks with this augmented reality training. So similar to that CRPS study, we do the 10 minutes of brain stimulation followed by 15 minutes of AR training immediately after on each session. In our second group, we use the exact same AR training, but now we precede that training with sham or placebo rTMS. And so the real goal here of this intervention is to determine if rTMS has a greater enhancement of AR training combined with compared to AR training alone. And again, this is preliminary data. We're 2/3 through our data collection here. But if we look at pain intensity here on the left, we can see the real group immediately post-intervention, and then at the 2-week follow-up, the sham group here, we see a 21% reduction in the real group and a 28% reduction in the sham group in terms of pain intensity. But interestingly, at 2 weeks, we see a further reduction in pain intensity in the real rTMS group, and we see a bit of a regression in pain intensity in the sham group. And one of the most exciting results that we're seeing right now is the improvement in neck disability index. So this is a measure of the patient's physical functional capability of the neck. And we're seeing a 26% improvement in the real group and a 51% improvement in the sham group in terms of their neck disability following training. And at 2 weeks follow-up, a similar trend that we see in the pain intensity, which is a continual increase in improvement to 34% in real and a bit of a regression at 34% in the sham group. And so again, these results are preliminary and we're still finishing the study. But what this might suggest to us is that the AR training is driving the main benefit during the treatment, but then rTMS may have a neuroplastic protective effect where it may maintain the benefit of the therapy beyond the treatment period and potentially enhance that benefit after the therapy itself. And this really is exciting for new ways that this could be implemented clinically, where we consider an rTMS top-up day, and then a patient would go home and perform the training in the comfort of their home and come back to clinic when needed to provide these top-ups. So it's a really exciting opportunity here, and we're looking forward to finishing this collection. And just quickly here to look at some more data, we see improvements here on the left in the pain interference of the patient, so moving from moderate to mild. And we also see improvements in physical function and ability to participate in social roles and activity. And lastly here, looking at range of motion, we see improvements in range of motion in both the real and sham groups. And this is in all 4 planes, so movements of the neck to the left, to the right, up, and down. And so we're really excited about these results and looking forward to collecting and finishing this study. And we're also performing a study using the ARST by itself as a monotherapy without rTMS to see the benefits of the therapy by itself. And just briefly here, before moving into how rTMS and chronic pain can be used within clinical practice, I just wanted to showcase some of the other work that we're doing here in the lab that will be coming out within this year. And we're working in other pain conditions. So we have an RCT using rTMS in patients with fibromyalgia, as well as an RCT using rTMS in patients with painful diabetic neuropathy. And we're also using rTMS in other special populations. So we're using rTMS plus this ARST training to treat vestibular imbalance issues in post-concussion syndrome. We're using rTMS plus balance training in dementia and Alzheimer's disease. And we're using paired pulse TMS for the treatments of Parkinson's disease. And so we're really excited by this opportunity to use rTMS within these special populations as a monotherapy, but also in combination with sensory motor training or balance type training interventions to potentially improve the outcome for patients and benefit these populations that typically struggle with current treatment options and therapies that are available to them. And moving into Neuro-Mod and how Neuro-Mod kind of was created as a result of this research, What we found when we were doing these studies is that when patients would complete the research, the first thing they would say to us is, how do I get more of this? And how do I get more rTMS for my pain? And truthfully, at this point within our area in Canada, there really is a lack of opportunity for patients to experience brain stimulation, which may be beneficial for them outside of research. And so there's a real lack of accessibility. And this is what inspired the creation of Neuro-Mod, where we can take our expertise in research, not only from the evidence that we see in our own studies, but also best practices and evidence-based practices that we see globally, and inform clinicians on how they could use these protocols and implement rTMS for their patients within their practice. And so ultimately, Neuro-Mod is a consultancy that offers a comprehensive research-backed approach to optimize and expand rTMS use into these investigative off-label therapies within clinical practice. And really, our mission is to revolutionize how we manage and treat disease and ultimately provide a effective, safe, and non-invasive treatment options using rTMS and capitalizing on the benefits of rTMS for these various special populations. And we do this through a three-pillar approach. So we focus primarily on treatment of the patient. We work with clinicians to train and educate on evidence-based protocols that can be used off-label for pain and other off-label applications of rTMS, and also technological integration. So the sensory motor training that we've developed in research, we can implement within clinic with physicians to be used in conjunction with rTMS or alone to benefit the patients that they're seeing within their practice. And what we provide really is two expertise packages to clinicians. The first is for clinicians who do not currently use rTMS, but would like to include rTMS within their clinical offerings. And what we provide is liaisoning with Magstim for the purchasing of equipment to furnish the rTMS services. We provide hands-on technical training, theory, best practices, and safety for the use of TMS within your clinic. We also provide you with education, the most up-to-date protocols in research that we're using for the conditions that you're interested in treating within your practice, whether that be chronic pain or other off-label applications of rTMS, or as well as on-label applications of rTMS. And ultimately, this tech integration piece where we can combine these new trainings or these new developments that we've created with rTMS to enhance patient outcomes and provide support to the clinic in these areas. And what's important to note is that in this area of investigative use of rTMS, it's a very rapidly evolving field as new research is published. And so our role in Neuro-Mod is to understand the latest in evidence-based practice for these off-label conditions and provide that expertise to the clinician to continually optimize and enhance the offerings that they're providing in their clinic for these off-label uses of rTMS. And lastly here, we also work with clinics who are currently using rTMS primarily for on-label treatments such as the treatment of depression, and expand their services through education, training, and tech integration into these off-label conditions to really benefit a larger proportion of the population that we can see effective relief for using rTMS. And we're really excited with ARST and bringing this to market by the end of this summer as a monotherapy and also as an adjunct therapy with TMS. And so this is something we've been working on now for the last 2 years, and we're really excited to soon launch into market as an application that can be used within clinic or at home with the patient. And ultimately, our team is myself, Dr. Aimee Nelson, and Dr. Harsha Shantana. So we have both clinical and scientific expertise in rTMS pain management. We also have advisors in engineering and business strategy, and we work with collaboration here with Magstim and with Physiotherapy Center in Canada. And so with that, I'd like to thank everyone for listening to this webinar. And if you have any questions or would like to contact me, I have our contact information here on screen and our website as well. Thank you very much.
Fantastic. Thank you, Stevie. Thank you, Aimee. Thank you. This is very enlightening. Lots of fantastic applications, particularly for people who are dealing with things that have not been addressed on a TMS level. So I think we've had a range of questions coming in, and we've got a couple more coming in right now. I'm going to turn it over to John Leadham to kind of help us guide on some of these things, and we'll go from there.
Great. Thank you, Mark. Thank you, Stevie. That was fantastic. What a great overview of the work that you guys are doing and the exciting results that are coming out of yours and Aimee's lab, actually Aimee's lab. But that was fantastic. I have a few questions coming in. Anybody else that wants to send them in, please keep them coming, and we'll start working through them. First question kind of came in about your early part of the presentation, and had asked if you had any those studies with controlled sham conditions.
So the studies that I presented here, the CRPS one and the neuropathic pain one, was an open label study. The chronic neck pain study is sham controlled, and the studies that we're currently running are all sham controlled. So the studies presented here were our initial work within the chronic pain space, and really the focus of that was to create pilot data that we could use for grant application to fund larger RCTs. And so we're working in those RCTs now, using placebo-controlled rTMS with real rTMS in these studies.
Great, thanks, Stevie. Next question that I have on my list here, was the muscle representation M1 chosen according to the affected muscles in CRPS? And what if the patient can't tolerate the stimulation because of the muscle twitching that you may see because of the TMS stimulation?
Yeah, it's an interesting point. And when we look at rTMS stimulation across chronic pain, the initial idea is to target representation within motor cortex that's representative of that painful limb. But there's been a lot of data and RCTs and meta-analyses that have come out and demonstrated that the somatic topic representation of M1 in terms of where you target doesn't change the effect on pain intensity. So typically what we use is the hand representation of primary motor cortex as the stimulation target. And the real idea of why we don't need to be somatotopically targeted is because the effects we think are occurring deeper in these more diencephalic areas within the brain. And we're using the motor cortex as a window into the connectivity with these regions that are really responsible for pain inhibition and causing this pain relief. And so we can get at that through hand representation. There has been work in CRPS where participants would get brain stimulation to vertex for patients that had lower limb CRPS, or hand representation for patients with upper limb CRPS. This has been done also in neuropathic pain, but again, there isn't any data yet to suggest one being better than the other, than just using the somatotopic representation within hand. To the point about tolerability, the stimulation we do is sub-threshold. And so we are performing it at an intensity that does not elicit any motor response in the patient. And so even in these CRPS patients that a light touch is very painful for them, they were all able to tolerate the stimulation procedure and quite enjoyed it and found it comfortable.
I'm just going to add to that. So I think the question is, what if the patient cannot tolerate the stimulation due to muscle twitches during the searching for the hot spot and the threshold? So during that, of course, it's super threshold. I think the key is to find a location in motor cortex in which an MEP is available. And when you have that MEP, my recommendation there would be to use that location, to not search further with suprathreshold stimulation, and then deliver the subthreshold stimulation at that location. And that sometimes is, yeah, go ahead, Stevie.
I was going to say, I've also seen work where they'll measure out C3 and just use that as a target and use a generic MSO basically for the stimulation, and just fluctuate the MSO based off of seeing a motor response or not, rather than searching at a suprathreshold stimulation.
And I guess that would be a good idea if you weren't getting any MEP whatsoever at a suprathreshold stimulus.
And that's an important point as well, because these patients are on a lot of additional medication when they are coming into these studies. We do see very elevated thresholds for these patients, some as high as in the 80s and 90% MSO. And so not necessarily will we always get an MEP to base our rTMS treatment intensity off of. And so we really try to work within a range that we think is effective for the patient and the MSO in those specific type of situations.
Great. Thanks, Stevie and Aimee. We know that with pain patients, they're quite often on multiple types of medications. Are any of these contradicted for rTMS?
So caveat to that, yes. So what we do is when we have a patient come into a study, we get their full medical record and profile of what they're currently taking, and we'll look in the literature to determine if there's any contraindications or not. We have seen medications that patients are on, especially antiepileptics, that a lot of the CRPS patients are on, that would be classified in literature as contraindicated. Based off of the severity of the patient, though, and the clinical expertise that we have in these studies, the idea was still to try the patient, and we have not had any adverse events to date. So I don't want to speak too specifically because in research, there are medications that we would deem as contraindicated, but it comes down to a medical decision as whether that risk is worth trying the patient or not. In the situations we've had, we've not experienced any adverse events, even with medications, antiepileptics, that traditionally in research have been described as contraindicated.
And you think that's mostly because you're subthreshold on your stimulation?
Exactly. Subthreshold, 10 hertz stimulation, lower frequency. If we were to use something like ITBS, we would be, I think, approaching this differently.
Right. Another question has come in here. Have any biomarkers predictive of responsiveness been identified in your data with CRPS?
So one of the ones we see in our data and more globally in pain is a measure of intercortical inhibition. So short latency intercortical inhibition, or SICI. We take this measure using traditional paired pulse TMS. And what we see in our data and also in literature is if the patient has a reduction in inhibition at baseline, that they are more likely to respond to the stimulation and see an improvement in that inhibitory control. And so that's one marker that we're starting to see come out of the literature. A lot of that's in neuropathic pain, but the depth of SICI or lack of SICI at baseline may predict someone's response to rTMS. There's also work being done now in EEG as well to categorize different changes in power within different frequency bands and using that as predictive markers for treatment outcome. So the data there is quite new. We're doing that work ourselves. Right now, SICI, I would say, is one of the main outcome measures, but we need a more fulsome understanding of different biomarkers at baseline to predict treatment outcome. And we're not there yet in that area.
Okay, more questions coming in. I didn't scroll down far enough, so I found a whole bunch more questions. So I may be skipping around a little bit. I think that one was answered as far as, well, I'll just make sure. So this question asks, what is your treatment location when you're using it alongside of the AR device?
Sorry, did you say treatment location?
Yeah,
Yeah.
I think you mentioned it was M1, but I just wanted to
Correct.
clear that
And
up.
the treatment isn't during the AR as well. So it's the rTMS, and then after the rTMS, we move to AR. So there's never a simultaneous rTMS delivery with AR.
Right. Question for Neuro-Mod here. Can you explain more how it is possible to treat patients who have off-label conditions in clinics?
So at least within Canada, I'll speak to our experience here working with clinics in our area. Right now, it's completely off-label and private treatment. Typically, a patient is referred by a pain specialist for the treatment to a clinic, and then the treatment is performed at the clinic that's doing rTMS typically for depression and have now expanded services into chronic pain. But there's the referral from a pain specialist indicating this as an investigative use of rTMS for that patient, and it's a private pay out of pocket service right now. There is no insurance or provincial or federal coverage for rTMS for chronic pain in Canada. And to my understanding, the same in the United States. It's also out of pocket and private currently.
And just to add to that, if you were an existing clinic running psychiatric patients for MDD, let's say, do you think this is something that's easy to add to your practice to help out more patients? Or
So we've worked with several clinics in the area that are psychiatric clinics for the treatment of depression. And those are the ones that are now implementing it for chronic pain. And we've seen a seamless integration as long as the referral network and physicians to support the chronic pain treatment are there. The infrastructure is already there for rTMS, and so it is a natural transition. Once they know the protocols and the treatment parameters for the different pain conditions, it is quite of a natural progression if you're already using rTMS in these psychiatric conditions.
Okay. We see quite a bit of comorbidity in clinical situations. Of course, patients show up with depression and pain and whatnot. But how do you deal with that in the research conditions?
Yeah, I'll let Aimee speak to this a little bit as well, but it is a big challenge. All these patients that come in have comorbid depression, anxiety, other psychological issues in addition to their pain, even different types of pain experiences. A lot of the CRPS patients also present with fibromyalgia, for example. And so it is a really complex challenge to be able to understand the nuances of how rTMS is affecting pain versus depression or anxiety in these patients, or maybe we're improving depression, which is then improving pain. So it is quite challenging. What we do know is that, and we see this in our research, each patients respond in both the psychiatric areas, such as depression, anxiety, and in pain. And based on research in neuropathic pain that tries to tease these things apart, we see that the driving effect is more likely due to the pain based off of the time course of the outcome. So typically, if you were to look at this more daily, you would see an improvement of pain start to occur after 5 sessions, up to 2 weeks of sessions. And then we see the improvement in psychological implication as well. So it's potentially the patient's feeling better in terms of pain, that's then improving their psychological condition. And so really understanding it at more that level of timing, I think is one way to look at it, but there is no best approach yet. It is a challenge within the chronic pain space.
Well, I'd like to add to that and say that I think our research has evolved over the last 4 years. So if you looked at a snapshot of us 4 years ago, we would think of, okay, we have patients with complex regional pain syndrome, and that's all they can have. So we're looking for a very homogeneous group. This is not possible. So we've learned that we have to widen the inclusion criteria to allow different people with comorbid conditions into our studies. And quite often we've had the instance where someone experiences chronic pain condition plus depression, and both are improved following stimulation. We've had that. We've also learned over these years, in addition to comorbid conditions, that the number of treatment sessions are really important. So research studies that we've conducted that have 10 or fewer bouts of stimulation really don't have an effect that is long lasting or even pronounced. They don't supersede the sham effect. So we know now that when we do brain stimulation and set up a study, in addition to being more relaxed in our eligibility criteria, we also plan studies that involve 6 weeks of stimulation, at minimum 20 sessions, likely more along the lines of 30.
And I just wanted to add to that. So a really interesting paper came out at the beginning of this year, Thomas, in 2025, and it's the longest understanding of rTMS and neuropathic pain in terms of response and how to maintain response. And what's the conclusion of this paper is that you try the patient with a certain number of sessions. This paper suggests 5. In our work, we typically suggest at least 10 sessions. If the patient then responds to that, you maintain the patient with monthly top-up sessions. And that paper by Thomas indicated that in some patients, you can actually prolong the analgesia effect of pain relief up to 10 years following that initial bout of stimulation. So it's a really promising outlook clinically, where a patient can have a relief that can be long-term and maintained with rTMS. But to Aimee's point, we need a certain number of sessions at baseline to cause that effect. It's a cumulative effect that occurs over subsequent sessions that's then maintained for a long course of treatment or maintenance.
Great. I'm going to quickly move through as we're running out of time here, just a kind of an add-on to the practice management side of it. Does adding TMS use for the treatment of chronic pain change the patient flow or the way that the clinic operates any from what they would normally do with their MDD?
It depends on the clinic and what their capacity is. Obviously, if the clinic's already at capacity for MDD treatment, we're adding more patients into that workflow, and typically this could be achieved by another device, for example, another room, another technician. We've also worked with clients that have a larger clinic itself, and MDD is a portion of that clinic, and so the MDD treatment isn't at full capacity, and then the time that they're not using MDD is supplemented with chronic pain treatment. So we see both avenues for that.
Of course, as a manufacturer, we like the first avenue the best. That's a little biased opinion. One question about your AR device. Will you be seeking FDA clearance on that device and the app?
Yeah, so right now we have a Health Canada establishment license for the ARST. We're just in that process right now. So it's considered a Class 1 medical device. And then the goal is to go into the FDA as well. So it's a Class 1 medical device, so we don't need, at least in Canada, a regulatory trial for it. But once we launch, we'll be moving into the FDA and have advisors to help with that process as well.
Great. I see Mark coming back, so I will.
Mark is coming back to say, we have fun here at our jobs, don't we all, everyone? So, one more question, John. I think there's maybe one more in there about parameters.
Just a real quick, just to review the stimulation parameters that you used in your protocols. It's probably in your publications as well, but maybe just a really quick summary of what frequency, what pulse interval, things like that.
So this is more general. We see that the parameters do change depending on the pain condition and the patient itself. But generally, and this has been shown in meta-analyses of large RCTs, what is the primary target is primary motor cortex, stimulation frequency, typically 10 to 20 hertz for stimulation. The MSO, typically between 80 to 90% of RMT for MSO. And what's suggested is anything greater than 1,000 pulses of TMS. So typically between 1,000 to 3,000 pulses. So this is very general, and it gets more nuanced when we look at specific pain types and phenotypes. So it's not a one size fits all approach. Right now, with primary motor cortex as the target, it is, at least in conditions that aren't fibromyalgia. But in terms of these actual stimulation parameters, timing of the pulse, this is more nuanced and really reflects the condition you're working with and even the patient level as well.
Fantastic. We're going to kind of land the plane, as they say, because I want to keep people on schedules. For those of you who ask questions, we very much appreciate it. For those who ask questions we didn't get to, we're going to follow up because I have a record of all the fantastic questions that you've asked. I want to thank everybody here for your time and your energy and for changing patient lives. Ronnie, do you have any closing thoughts?
I don't, Mark. I think you summed it up beautifully. Just a big thank you to Doctors Nelson and Foglia. And you're doing amazing work. This is why we're all so excited to come to work. As Mark says, we have fun at our job. We have fun because it's always changing, it's innovative. We get to work with brilliant researchers and to commercialize some of this stuff to truly make life better for everybody out there. So thank you both for your dedication and passion to alleviating pain and suffering.
Thank you, Ronnie. You'll see the email there that Stevie's put up with their email. You can also reach out to marketing@magstim.com, and we're happy to help you out. So I'm going to send everybody off to have an amazing rest of your week. And thank you all. And we look forward to seeing you again on more webinars.